questions and answers. We do, as Joe said, have a lot of ground to cover today, so I am going to get moving. Joe has said lots about me, so I don't think I need to say very much more than that, other than thank you all for joining. As Joe said, my name's Ita, and I'm a psychiatric pharmacist here in Ireland, and I've just finished a PhD looking at the evidence-based management of antipsychotic-induced weight gain. And I had a particular interest and have a particular interest in using pharmacological adjuncts to help support people when it comes to systematically managing this side effect. So with that in mind, Joe, will I get going, or do we want to have a look at poll results first, or what?
Can we see the poll results? I know Lauren's just tried to reshare the poll and has just messaged me that she can't do that, so I'm guessing that's a feature of Teams. So we'll just go with the people who have inputted into the chat already. But if anyone wasn't able to fill the poll out and is interested, please put your responses in the chat group. So we're interested in trying to find out if you can prescribe metformin in your setting, if you prescribe, or if they are prescribed, not necessarily you prescribe, but if they're used in your setting, metformin and GLP-1s, and what are the barriers that you foresee at the moment to being able to successfully prescribe those within your setting. Use the chat to help continue these conversations, because this all helps us formulate our interests as well. Yeah. So can we see the poll results, Lauren? Is that a thing?
Yes, you're able to see the results of the responses so far.
77 responses view poll, so we can all view that. So we've got 56% of people say that metformin is used, 11% interestingly say GLP-1s are used, and there's 9% of people where the response is not applicable, and that includes someone like myself, because I'm a researcher and obviously as a psychologist, I'm not working in a setting at the moment. So that's great. Thank you.
So could you repeat those numbers again? So it was 56.
Yeah, sure. So yeah, 56 you're using metformin. This is a percentage. So 12% GLP-1s, 22% is nothing, and 9% of people who have filled in the poll, it says is not applicable, and we've had 78 responses.
Okay, good stuff. It just gives me an idea of what to target in the slides. Okay, so I'm going to turn off my camera just so I said that I keep my internet connection. Please God.
I'm going to hand over to you now, Ita, and you can take it away.
Can you let me know that you can see this?
Yeah, sorry, I realised I was on I was on mute there. Can see it, no problem.
Great. So let's jump straight in to it, given the fact that we have a lot of ground to cover. Oh, why does my screen now not want to move when I want it to move? I know. Let me see. All right, it might be because I have two screens on the go. Let me check if I do this. Okay. No. Okay. All right, now, 2 seconds. Okay, there we go. It's always the way. So I don't have any declarations of interest to declare. So in terms of what we're going to discuss today, we're going to look first at the variable prognosis of antipsychotic-induced weight gain. And this is important because often as clinicians, including myself, we want one-size-fits-all rules for everyone. We want to know, can everyone who starts on an antipsychotic, for example, be prescribed a GLP-1 agonist? Should everyone be prescribed metformin, for example? Should everyone be given dietary and lifestyle interventions, etc.? But the reality is, for us as clinicians, the prognosis is extensively variable. And unfortunately, that means that we need to be a little bit more individualized in our approach, although I will share some good kind of clinical rules today that hopefully will be of help for people in terms of identifying those people who need more intensive interventions. We were going to just look at GLP-1 agonists, hence the name of our talk, but actually in preparing these slides, I thought that it was important to look actually at metformin also, because that really helps us to understand the comparative role of these different interventions. Oh, if everyone could just turn off their mics, I can hear a little bit of background noise just to keep it clear.
Ita, have you gone quiet? Because I can't hear you at all.
Sorry, did I cut out?
Yes, I'm wondering if someone muted everybody and in essence then muted you. So when we mute, we have to selectively mute because otherwise you end up muting the recipient. Okay.
Well, at least you told me about it before I kept going. When did I cut out? Just a minute ago?
Literally as soon as you asked people to turn off their mics.
Okay, great. Well, look, I'll jump back in here. So I am just conscious of the fact that lots of people are joining from the UK. So I did want to address funding because obviously that impacts a lot of the practical utility of the information that we'll give today or provide around GLP-1 agonists. So we're going to talk about their evidence base in managing antipsychotic-induced weight gain, but I am conscious that funding does impact actually a lot of the recommendations that we'll give. So I did want to acknowledge that at the start, but also I suppose say that, clinicians from all around the world are free to join this. So we are covering their evidence-based use. Oh, it doesn't want to move again for me. Sorry, because I went in and out. Apologies for the technical issues. That's frustrating. So in terms of managing, let's make sure that works. Yes, antipsychotic-induced weight gain. I always like to begin with the end in mind. And I think it's useful for us to have a couple of points with regards to take-home points for our practice. So what I would love for people to get from today's talk is the first thing, as I said, the prognosis of antipsychotic-induced weight gain is extensively variable. We know as practicing clinicians that the actual choice of antipsychotic that we're prescribed makes a big difference in terms of someone's long-term prognosis, but even people who are prescribed a high-risk antipsychotic like olanzapine or clozapine, their weight outcomes can be very different. So we need to adopt an individualized approach. Early intervention, people will intuitively appreciate, is of course paramount. And what we can use in terms of pharmacological adjuncts actually is metformin. So we're going to look at the evidence today for metformin as primarily an agent which works to induce a plateau of antipsychotic-induced weight gain. That is, it's effective to prevent continued weight gain, not actually to reverse established weight gain, despite its current roles within antipsychotic-induced weight gain guidelines. So we'll have a look at the evidence for that and actually show that that's what we need to be using metformin for, as an early intervention or a preventative agent, not a treatment of established weight gain. In contrast, GLP-1 agonists, the current evidence base supports their use as only a treatment of antipsychotic-induced weight gain rather than prevention. And this kind of goes against a lot of the current discussions around GLP-1 agonists, and possibly because of their interest and obvious benefits if used among our cohort of patients. But actually, randomized controlled trial evidence is not there for that. And they come with a much different risk profile compared to metformin that we'll look at today. There is an exception when it comes to that, which is clozapine, and we'll look at why that might be in the coming slides also. So most people here, and given the interest that we've had in the topic, will appreciate that antipsychotic-induced weight gain is intuitively just difficult to manage. We have lots of issues with managing it, and we keep coming back to the same conversations, and there's lots of different reasons why that is. The first is the extensive inter-individual variability, as I've talked about already. We know weight gain in our settings is multifactorial, particularly people in forensic settings, for example. I know that's come up here before. And what proportion can we attribute to antipsychotics, hence why something like metformin or a GLP-1 agonist might be appropriate to consider, and what is due to lifestyle or behavioral, where actually diet and lifestyle interventions might be very appropriate in that cohort of people. There is some guidance that we'll talk about today, but it's scant, and a lot of the time it's actually incorrectly adopting guidance that we would give to people like you or I, or someone who doesn't take antipsychotic treatments, and not acknowledge the fact that actually antipsychotic-induced weight gain is a very, very distinguished and unique cause of obesity or overweight and obesity. And we need to actually make sure that the advice that we're given is reflective of the evidence base specific to the use of these interventions among people who have gained weight due to antipsychotics, not just people generally living with overweight or obesity. There is some evidence to support some non-pharmacological interventions, but even where there is evidence, those are highly resource intensive, and that creates concerns around equitability of access to interventions, which is, of course, an issue with regards to GLP-1 agonists too. Metformin less so because it's cheap, which makes it a big benefit in terms of lots of people from different backgrounds, particular socioeconomic backgrounds, being able to access this as an intervention. We're essentially repurposing the use of these medicines, particularly metformin, when it comes to using them in the context of antipsychotic-induced weight gain, which isn't uncommon in psychiatry. We often do that or use medications outside their direct evidence base, but questions come up regarding responsibility, regarding shared care, regarding off-label use of these medicines, and indeed their appropriateness of prescribing them outside the setting of diabetes management. And that's something we're going to discuss today in terms of, is it appropriate to prescribe metformin and GLP-1 agonists outside of diabetes management settings? And if so, and I'm assuming lots of people are doing it, 56% isn't bad in terms of metformin. But what are the risk considerations that we need to consider, or what do we need to be monitoring or managing for if we are recommending these medications? So everyone needs support with managing antipsychotic-induced weight gain, but in line with that more individualized approach, who needs the most support and therefore often needs to benefit from more intensive interventions, particularly GLP-1 agonists? So often there's a lot of talk around prevention or treatment of antipsychotic-induced weight gain, but I hope to introduce this kind of additional concept, which is early intervention, as a third kind of pillar or parameter. So often this is, or what I'm talking about, I suppose, in this context is, say, amongst all people who are prescribed olanzapine, we'll say, we know that in the context of a first episode of weight gain, about 80% of people are going to gain a clinically significant amount of weight, but we don't know actually how much weight they're going to gain. And it would be very useful for us for lots of different reasons, whether at the point of antipsychotic prescribing or early in the experience of antipsychotic treatment, if we could identify those people who are likely to have the worst long-term outcomes so that we can target our often resource-intensive interventions accordingly. So this looks at a typical prognosis of antipsychotic-induced weight gain, and this is taken from cohort studies. And this is important because when you look at lots of the randomized control trials that look at the efficacy of antipsychotics in different settings, they will often report an average weight gain of a couple of kilos over about 16 weeks on average. But obviously, for anyone who's familiar with prescribing antipsychotics, independent of the context, these are often prescribed for years, at least 1 to 2 in the context of psychosis management, potentially a lot longer. So we need to look to observational research to look actually at what is the continued trajectory of weight once someone starts on an antipsychotic. And what you can see here is in the bulk in this chart here, the bulk of weight gain occurs within the first 12 months of treatment. After this time, it can continue, although it usually does so at a much slower rate. That being said, it still can continue in many cases, and you can imagine if someone is on an antipsychotic for a very prolonged period of time, that could be clinically meaningful. But as you can see, within the first 12 months of treatment, that offers us a unique opportunity for early intervention or the use of preventative interventions. So whilst we know that the majority of people who take antipsychotics will gain a clinically significant amount of weight over their lifetime of being antipsychotics, on antipsychotics, that's typically defined as a 7% or greater increase in baseline body weight. And that's called clinically significant, as we usually start to see adverse impacts on cardiometabolic markers once someone does experience that percentage of weight increase. And that's particularly important when it comes to antipsychotics, as most people will be familiar with who work in clinical practice. The extent of weight gain, or the typical pattern of weight gain, tends to be the central accumulation of adipose tissue, which is quite bad, obviously, in terms of heart health, risk of diabetes, etc. But when you look at the actual absolute weight gain figures, what you can see, and this is taken over a 3-year period for people prescribed a multitude of different antipsychotics, that the average weight gain estimates are around 12 kilos. But look at that measurement of variance alongside the average weight gain estimate. Actually, what you can see is it's almost as big as the average weight gain, which shows the difference in trajectory that occurs among people and really adds to the complexity of management. But is there anything in clinical practice actually that we can use to help to identify those people who are going to gain the most amounts of weight longitudinally? And this was something that we looked at in 2023, actually, our research group, to look at whether or not we could use any currently available parameters that we typically collect in an objective way in clinical practice to identify those people when they're new to antipsychotic treatment in the context of psychosis management. Are there any baseline factors, whether that be clinical, whether that be sociodemographic, whether that be metabolic, for example, whether that be weight status, that we could use actually to say, okay, if this person is starting on olanzapine, they have X, Y, and Z risk factors, they are likely to gain the most amount of weight. They should be targeted for preventative use of intervention, referred to individualized dietary services, for example, or they actually should be prioritized to start on a lower risk antipsychotic because their risk of weight gain is so high. So I won't go through it all in detail, but really it's just to say we looked at 72 different prognostic factors, and these are essentially any variable that is associated amongst a group of people with a defined clinical outcome at a defined time point. In this Sankey diagram, this just looks at the most common prognostic factors that have been studied in this area, with the color of the lines indicating the quality of supporting evidence. For our purpose today, really what we saw is the best or the strongest quality evidence is for trend of early weight gain in predicting those who are likely to gain the most amount of weight longitudinally. So what we found is for every 1 BMI point increase at 12 weeks, you gain almost an additional 1 point BMI increase at 12 months. So what you can see is these people who are gaining the most amount of weight within the first weeks and months of treatment, they do worse longer term. So if someone gains, for example, no weight at the start of quetiapine treatment or olanzapine treatment, they are very, very unlikely to gain a clinically significant amount of weight that is attributable to antipsychotic treatment. And this reflects our understanding of what Jazz would have spoken about in a previous talk in terms of antipsychotics work to interfere with those homeostatic mechanisms responsible for appetite control. And that happens within weeks of starting treatment. So it's these first weeks and months of treatment that are essential that we implement our early interventions, but those people who are gaining the most amount of weight within those weeks, and particularly quite quickly, they need to be targeted for active early intervention. You see a lot of focus on the research around genetic correlates or changes in the receptors that antipsychotics work with, for example, or different variations in gene expression, I suppose. But really, actually, that early trend in weight gain is likely just the phenotypic expression of those people who are at highest inherent genetic risk, and is probably measuring that trend of weight gain within the first weeks of treatment is likely a much more efficient way of identifying those people who are at higher inherent risk. So let's say we get into the management, we do identify people either who have gained a lot of weight or who need current access to pharmacological adjuncts. And today we're going to focus on metformin and GLP-1 agonists, of which the most commonly well-known are liraglutide and the next second generation GLP-1 agonist, semaglutide. We're going to focus on those, but I've acknowledged in this slide that there are other interventions that can be used sometimes also. So this is an example of a typical management algorithm. I've extracted the ones from the BAP guideline, and they're old at this stage, 2016, and also a WHO guideline as well that looked at physical health monitoring and interventions in the context of SMI management. And typically what they recommend are these types of hierarchical management algorithms, and that's very much the population level weight management approach that we see recommended by NICE or other organizations also in terms of managing overweight and obesity more generally, but also at the population at large too. And what you see is interventions like metformin, but also GLP-1 agonists would fit into this now, relegated to a last line management intervention, only to be tried once all other interventions have failed. Unfortunately, despite its importance in the area, there are no current recommendations addressing preventative or early intervention in the context of these international guidelines. And a lot of the time, the evidence which is being used to inform these guideline development groups' recommendations actually are these kind of meta-reviews. This was published in 2019, which is really, really useful. But a primary barrier actually, when you look at the evidence that informed it, is often lots of different etiological causes of overweight and obesity among those with a severe mental illness, or in this case, schizophrenia, are lumped in together. So again, we don't have a lot of very specific secondary sources of evidence synthesis that look at the evidence of efficacy of these interventions, specific again to that really unique cause of overweight or obesity that's induced by antipsychotic treatment. And that's very important if we are to inform guideline recommendations in an accurate and evidence-based way. And this is something that has not been adequately considered by previous guideline development groups. This is an example of the chart of the effect size from that 2019 meta-review. And what you can see, and these are typically this is typically one of the arguments used to support relegated or delayed use of metformin, is that on average, it has a pretty average effect size and it's outweighed by other interventions. But again, remember, this is not just looking at those studies that look at antipsychotic-induced weight gain as the cause of weight gain. But what about actual studies that look at metformin, again, very specific to the cause of weight gain, that is antipsychotic-induced weight gain? And as you can see, when you lump them all together, and this comes from a 2016 systematic review and meta-analysis, which is old at this stage, but it's not a rapidly developing area. What you can see is that on average, you get a weight gain loss of about 3.5 kilos with metformin, which again, when you look at some of the guideline development documents, is used as an argument to support delayed use of metformin. So that is, if I'm a person that takes quetiapine or olanzapine over a prolonged period of time, I'm very likely, particularly with olanzapine, to gain much more than 3 kilos of weight over my course of treatment. I also need to consider, as a guideline development group member, the tablet burden. I need to consider the risk of side effects, for example, and also perhaps you may make the argument that it makes pragmatic sense to use lifestyle interventions before adding on another tablet, although of course there are differences between appropriate and inappropriate polypharmacy. I picked this systematic review and meta-analysis as they did really useful subgroup analysis that really supports actually using metformin in a much earlier and broader sense if we do understand how metformin works, but also that we fundamentally consider the timing at which the intervention has been offered. So something that's often missed when people are drawing conclusions about how well any intervention works to manage antipsychotic-induced weight gain is the prognosis of the side effect. That is, how likely continued weight gain is. So if we think back to that 12-month graph, for example, or the 3-year extension of it, we see the majority of that weight gain occurring within the 12 months. If you actually look at the evidence base for when you implement or use metformin at different time points, and this is why I wanted to use this graph. Here's metformin use in first episode psychosis compared to chronic psychosis use. So you'll appreciate in first episode psychosis use that actually metformin is a new intervention among people actually who are relatively new to antipsychotic treatment. Among those who have a chronic psychosis episode history, they're going to have years of prior antipsychotic exposure, so they're well established on antipsychotic treatment and have likely already reached that plateau of antipsychotic-induced weight gain. This in the first episode group, they're in that first 12 months treatment where that weight gain is accumulating rapidly. So when we look at this 3 kilo weight loss that we saw on the prior slide, and we divide it into, or we do a subgroup analysis looking at metformin's efficacy in first episode compared to chronic psychosis, we can see that metformin is on average 3 times more effective in the first episode group. That's obviously a good enough argument to use it earlier in the majority of people, aside from pragmatics. But actually, why is that, or what's going on? When you look at the average weight change in the metformin-treated groups in both the first episode and the chronic psychosis groups, actually the average weight change is pretty similar. It's about -2.4, -1.6 kilos in the chronic psychosis groups. Actually, the difference, or what accounts for the biggest proportion of this mean difference, is what's happening in the placebo-treated groups in both cases. So what you can see in the placebo groups is that the weight continues to increase. And again, that's reflecting that rapid period of weight increase within the first 12 weeks. However, in the chronic psychosis group, you can see in the majority of cases, weight stays the same, or you see minor weight reduction. So actually the biggest proportion of this mean difference is accounted for. So 70% in the first episode group is accounted for through preventing this. So each time you look at the efficacy of metformin in terms of its effect size, you have to consider you're not only getting a small or modest weight reduction, but you're also preventing this weight. That doesn't happen in people who have been chronically exposed to antipsychotic treatment. Hence, this leads us to draw the conclusion, alongside considering metformin's efficacy when it's studied solely in randomized control trials as a preventative treatment, that actually metformin works to plateau weight gain, or its primary benefit in terms of managing antipsychotic-induced weight gain is as an agent that induces this plateau of weight gain rather than achieve those minor or modest weight reversals that often we have come to think of metformin as doing as well. So again, back to this picture, actually what we're trying to do with metformin, or what the bulk of the evidence supports, is inducing this plateau of weight gain early. And as I said, you also see that when you look at here, we're looking at metformin or trials when it's used early in antipsychotic treatment, but when you look at randomized control trials that look at solely at metformin as a preventative treatment, whether that's children, adolescents, or interestingly in the case of clozapine as well, actually what you can see is that the majority of that effect size is counted for through preventing weight gain. So an unintended consequence of sticking to the current guidelines in this area is actually that we wait too long to use an intervention where its primary benefit is in inducing a plateau of antipsychotic-induced weight gain. And that means for the majority of patients, by the time we actually start metformin, we have lost most of its unique benefits and the biggest benefits that we're likely to get from it, which is unfortunate, but it represents, as I said, a fundamental lack of consideration of the timing at which the intervention is offered. And this is important, whether it's a GLP-1, whether it's metformin, you need to consider when we're assessing the efficacy of any intervention, the likely prognosis of weight gain at that time, i.e., has someone already gained a lot of weight gain? They're not likely to gain anymore. Therefore, we might as well look at the GLP-1. Or are they early in that experience where actually metformin is likely to be a very suitable intervention, and compared to GLP-1 agonists, as we'll see, a much lower risk and lower cost intervention too. And this role of metformin as an agent which induces a plateau of weight gain actually fits with our understanding of how metformin works to reduce appetite, which adds biological plausibility to our mechanism. So this is a paper that I've referenced for anyone who is interested in it. But essentially what you see is metformin has multimodal action in terms of reducing appetite, but often what I say to patients is that it can directly target some of those signals between the gut and the brain that are disrupted by antipsychotic treatment that make it so difficult to control appetite. So you can see it actually has some peripheral effects in terms of there are some studies that support metformin as increasing the production of gut-derived hormones like GLP-1 or peptide YY that communicate with the brain to suppress appetite, but also that it has central effects too, in terms of it works in the hypothalamus, which is our primary regulator of energy intake and expenditure, to turn down some of those appetite increasing neural circuits which are activated by some of our antipsychotics' broad receptor activity. So it's essentially denting that mechanism which is responsible for increased weight gain before we have this kind of setting of a new body weight set point, which seems to be what explains the plateau of antipsychotic-induced weight gain occurring after about 12 months of treatment or so. So to summarize, before we look at GLP-1s, here's what the role of metformin really should be in terms of if we look exclusively at evidence-based in terms of antipsychotic-induced weight gain management. So it is suitable for use as an early intervention if it's feasible within your setting actually to monitor people's weight, that actually once people experience about a 5 to 7% increase in weight, that metformin should be used, particularly in those early weeks of treatment, again, because those are the people who are likely to do worse long term. It is appropriate as a preventative intervention in people who are prescribed high-risk antipsychotics, because if you're on clozapine or olanzapine, the majority of people are doing that. We can't monitor everyone, or you might have antipsychotics which are prescribed in a setting where weight monitoring isn't great, or in outpatient settings too. There may be other factors that might influence, and I've learned this from endocrinology or my work with endocrinologists in terms, and that would influence a lower threshold for starting metformin as a preventative intervention, and that's in the context of having a personal or family history of obesity. If you have a personal history of obesity, depending on the average weight loss that you need to achieve to be back at a healthy BMI, you may go for a GLP-1 agonist first, and we'll discuss that in the coming slides. Or if there are other cardiometabolic markers that mean metformin might provide additional benefits, so things like prediabetes also as well. So I hope that makes it a little bit clearer in terms of the roles of metformin as primarily a preventative and early intervention agent, and why it shouldn't be delayed or used as a treatment intervention, but more than happy to go over that again. And I know Lauren is kindly providing references to support this, so that people actually can take it away and put it in their own practice too. With that in mind, lots of the evidence for metformin primarily as a weight inducing or inducing a plateau of weight gain we've put in this paper linked down at the bottom here as an opinion piece published in Frontiers in Psychiatry. And I know Lauren again is going to share that, but we tried to really put that piece together to actually provide a space to make an argument for much earlier and broader use of metformin treatment. But also what we put in there was a slide or this image around risk associated with metformin, because as I said at the start, what comes up a lot is the appropriateness of prescribing these medicines in non-specialist settings. So that picture is in that reference and it's open access. If it's of use, please use it in your setting. But there are a couple of misconceptions that I just wanted to address before we look at GLP-1 agonists. The first is hypoglycemia. And again, all of this is explained in greater detail in that image and in that paper. Metformin does not cause hypoglycemia, and if you prescribe it in your setting, even if the person was diabetic, there is no need for additional blood glucose monitoring. Metformin works at the level of the liver and the muscle and the gastrointestinal tract to control glucose release and uptake to stabilize blood sugar levels and thus insulin sensitivity. It doesn't have any effect on insulin release at the pancreas, and unless a person is on other glucose lowering medicines, but then they would be managed by a diabetes team, you do not need to manage blood sugars or check them at baseline. Renal dysfunction is something that's come up around discussions around metformin to say whether or not actually it causes any renal damage. It doesn't. It's just that it needs to be dose reduced if someone has renal impairment, but that actually isn't until you get down to very low levels of renal function. So an EGFR of about 30 or so, which you're very unlikely to see in our typically much younger cohort of patients who would be eligible for metformin. Vitamin B deficiency is an issue with metformin. Probably about 10% of people get it. That being said, it is associated with long-standing use of metformin. You don't need to have a baseline vitamin B12 level. And actually, even according to MHRA guidance, when they talk about metformin and vitamin B12 deficiency, they only recommend a level in people where they have presenting symptoms associated with vitamin B12 deficiency, like neuropathy, for example, or obviously if it's objectively present on a blood test. Lactic acidosis is a general concern with metformin, but current risk estimates are about 1 in 10,000. And speaking to my colleagues in endocrinology, anytime they have seen it actually occurs in the context of multiple risk factors, and usually the person has no renal function at that stage, or metformin hasn't been dose adjusted. So it's not something we use metformin all the time that I've ever seen. And again, it usually happens in much older people with lots of additional comorbidities. So we've put together a guideline. We published this in 2022 or 2021, perhaps at this stage. It is 2021. Gosh, how time is flying. That look at how metformin actually should be used in terms of produced a set of recommendations for if you do want to use metformin as an early intervention, what dose you should use, how long you should use it for, what your treatment goals are, what deprescribing criteria are, and then the monitoring of side effects. So again, that's a reference that will be provided to you if you do want to adapt that guideline for use in your area. So we'll move swiftly on now to GLP-1 agonists. These are medicines which are becoming increasingly popular because of lots of different benefits. So weight reduction is one, but having lots of benefits also in the context of perhaps modifying cardiovascular outcomes for people living with overweight or obesity who are not diabetic or don't have a severe mental illness, and also improving cardiovascular and kidney outcomes among people as well. So we're starting to see them actually have a huge range of benefits, which of course for our cohort of patients who die early, primarily due to cardiometabolic diseases, these group of medicines have potentially huge benefits for our cohort of patients. We are interested in them for today's talk for these kind of three primary benefits, which help to explain their appetite suppressing effects. Now, they have actions similar to metformin, both centrally and peripherally in doing that. But again, they can help directly target some of those mechanisms responsible for increased appetite or that homeostatic disruption the disruption in homeostatic appetite control caused by antipsychotics. They can directly target that. So for obvious reasons, there's great interest in these medicines in our area. So there are lots of different GLP-1s. These are two second generation or newer ones, which is semaglutide and liraglutide. I'm going to focus on these in today's talk because even when you look at the first GLP-1 agonist, exenatide, in 2004, these newer GLP-1 agonists, aside from semaglutide being a once weekly preparation, when they're compared, actually these ones have much better weight loss in terms of average percentage weight loss from baseline body weight, with semaglutide being the best and liraglutide following after this. You do have different preparations, which clinicians will be familiar with in terms of, let's say, semaglutide. It's effective in diabetes management up now, actually, to a dose of 2 milligrams, but the optimum weight management dose is 2.4. The same with liraglutide. You see 1.8 milligrams used in diabetes management or 3 milligrams used in the context of obesity or overweight and obesity management. And the reason I mention that here is because often you see people, and this can be influenced by lots of different things, perhaps availability of the pens also in the more recent times, but actually being prescribed doses which are effective in the context of blood glucose management or HbA1c management, but not enough actually to have that appetite suppressing effect. So if we're going to prescribe them, we should be trying to get them to the highest dose, which is reflective of the evidence base specific to use of these medicines in overweight and obesity, also that it's tolerable too, which sometimes can come up as an issue for these. So prior to more recent studies, our evidence in this area or the interest in, let's say, semaglutide, which I'm focusing on here, primarily came from a series of trials called the STEP trials. And these looked at the efficacy of 2.4 milligrams of semaglutide once weekly in people who had or lived with overweight or obesity. But importantly, they excluded anyone living with a severe mental illness and anyone actually taking any weight increasing medicine. So this didn't reflect our cohort of patients, which was a concern because perhaps they wouldn't work as well in someone who was prescribed a weight-inducing medicine. But you can see for the first time, even compared to bariatric surgery, but falling behind bariatric surgery in terms of efficacy, getting really good average weight loss with these medications that we hadn't seen before. So an average of 11.8% or 12% weight loss over about, or baseline, or when compared to baseline body weight over about 52 to 68 weeks is the kind of typical trial length of these trials. More recently, we do have some randomized controlled trial evidence, and this is a systematic review and meta-analysis that looks directly at the efficacy of GLP-1 agonists, specifically here, exenatide and mostly liraglutide, in the context of those people who take antipsychotics and live with schizophrenia or schizoaffective disorder. So there was 5 randomized controlled trials, and these were relatively short term, looking at about 16 weeks. But you could see here they measure a different kind of primary outcome. But you see on average over that relatively short period of time, getting kind of 2-4 kilos weight loss or BMI change of kind of around 1 point over a short period of time, which was interesting. And it was the first time actually they had been directly studied for the management or the treatment of antipsychotic-induced weight gain. Again, no treatment. These were not a preventative use of these interventions. Thankfully, just before I put together this talk, this has been published in, I think, the start of July or June 2015. And this is the first randomized controlled trial to look at the efficacy of semaglutide among people treated with clozapine and living obviously with schizophrenia. And this was a phase 2 randomized control trial. So they aimed to recruit about 80 people, but because of issues with regards to accessibility of the medicine in Australia, so this was a multi-site study in Australia, only actually randomized 31 people in total to either semaglutide once weekly or placebo. So it is relatively small, but it is the first time we actually have randomized control trial evidence of the efficacy of semaglutide specifically among our cohort of patients. So they looked, as I said, at people treated with clozapine. Now, they had to be on clozapine for at least 18 weeks. And very importantly, they had to have no weight change within the last 3 months of treatment. So their weight was stable. So again, this was very much a treatment use of semaglutide in this cohort of people. So they went up to 2 milligrams, again, due to lack of availability to get the 2.4 milligram pen. But over a period of 36 weeks, they looked at the average percent change in body weight once people had gotten to 2 milligrams of semaglutide compared to placebo. And this is a chart looking at the outcomes. And what you can see is very quickly, actually, semaglutide separates from placebo, showing actually just how effective it can be where it does work. Compared to people who were on placebo, you saw about a 13.5% weight loss over 36 weeks, or 13.5% weight loss in terms of baseline body weight over 36 weeks treatment. So that's a lot over quite a short period of time, even among a small number of people treated with semaglutide. Importantly, this again was one of the first times where actually we had robust safety data also collected prospectively among our cohort of people, as lots of clinicians will appreciate. There was recently, based on some reports from the MHRA, the FDA, the EMA, or other regulatory agencies in countries around risk of psychiatric side effects with GLP-1 agonists, which doesn't come up as a concern with the likes of Metformin, for example. Here they found no difference in terms of PANSS scores. So when you look at positive symptoms of schizophrenia, negative symptoms of schizophrenia, or any change in clozapine or norclozapine ratios or plasma levels also, which you would expect given the fact that it doesn't actually induce liver enzymes in many ways, or GLP-1 agonists don't really come with a high risk of drug interactions. And as I said, this is really important because not only efficacy, showing that we're getting similar average weight reductions, whether they're used in the context of antipsychotic-induced weight gain or general overweight and obesity management, but actually that they're safe to use in our cohort of patients. And this is important because, as I said, you were getting lots of these regulatory reports specifically around increased risk of self-harm or suicide. Now, that happened in about 2023. And since then, both the EMA and FDA have come out and said that they've looked at all the reports that were available. They've gathered more post-marketing reports and now say actually that there isn't evidence to support that there is a robust link between GLP-1 agonists and any psychiatric side effects, whether that be suicidal ideation or other outcomes as well in terms of psychiatric outcomes. And you see that reflected now in the SPCs for these medicines as well, whether it be Wegovy or Ozempic, for example, there's no link or mention of monitoring for psychiatric side effects. There was another interesting study that I've linked if people are interested in, and this isn't specifically within people living with a severe mental illness, but they did actually look very broadly at lots of different serious and non-serious psychiatric side effects among people taking these medicines for overweight or obesity management or diabetes management. So these randomized controlled trials included in this systematic review did exclude our cohort of patients, but again, it's helping us differentiate between signal and noise in lots of the prior case reports, looking at increased risk of other psychiatric side effects. So they looked at 80 randomized controlled trials that included about 107,000 participants. And as I said, they looked at risk of serious psychiatric side effects. So that was things like major depression, psychosis, suicidal ideation, and non-serious, so an increased risk of anxiety or insomnia, perhaps. This is a difficult slide to read, so I've just put a quote actually from their conclusion section, but essentially it was, our key finding is no evidence for increased risk of psychiatric adverse events with GLP-1s compared to people treated with placebo who live with overweight or obesity as well. So the majority of evidence is saying there's no real risk in terms of worsening psychiatric side effects directly from these medications. Now, sometimes in our cohort of patients, people can gain excessive weight due to different reasons, and sometimes that can be psychologically protective. So you do see in in tier 3 or level 3 weight management services, actually there being lots of psychological supports for people when you do lose weight, because that can be psychologically triggering for some people. Also in the context of PTSD, for example, or sexual assault, where people again gain excess weight for different reasons. So it's not to say that some people don't need psychological support, but that's in the context of weight loss more generally, rather than them being attributable to our medicines that. So to finish up, these medicines do, of course, have side effects, and we need to consider these. I'm always really conscious of this, because this time last year, my dad actually ended up in the ICU due to acute kidney injury, essentially due to dehydration secondary to GLP-1 agonists. Now, also stupidity added into that in terms of not asking for help when things started to go down the Swanee a little bit in terms of dehydration. But it is something that we need to think of, because these medicines have a different risk profile compared to something like metformin. So they decrease drive for food, but they also decrease drive for water. So people feel less thirsty. Couple that on top of gastrointestinal loss due to side effects, and people can end up with acute kidney injury. Now, the likelihood is rare, but it is something that you do see and is mentioned in the product characteristics. So when we're counseling people about changing diet, etc., we do need to be explicit that people need to increase their water intake. And that again reflects that the primary side effects like metformin relate to the gastrointestinal tract. This is why in the case of metformin and GLP-1 agonists, we start the dose low and we build up slowly according to that product information, independent of the indication for the medication. Gallstones are probably the primary issue that happens with these medicines. So this kind of reflects physiology more so. So anytime someone starts on a medicine that significantly reduces appetite, you get fat decrease, or fat intake in the diet is decreased. And essentially what that can end up happening is that you get bile acid stored in the gallstones, because the trigger for its release is actually fat intake in the diet. So that ends up essentially getting sticky, and it can form gallstones. I have seen this a couple of times with GLP-1 agonists, although the risk estimate is relatively low. So you can see a number needed to harm of about 71. So you need to treat 71 people with liraglutide at a weight management dose. And we just use this as an example here in order to get one episode of gallstones, but still unpleasant, but actually not a reason that you can't restart it. But people do need to be cancelled on nutrition with GLP-1 agonists compared to metformin, for example. Pancreatitis is a more serious side effect, and for reasons we don't really fully understand why it happens. And again, the number needed to harm is quite low, about 500, but you'd see if you go and look at the literature, more recent risk concerns flagged by, I think it's the MHRA yellow card scheme around deaths from pancreatitis. So you have about 500 case reports of pancreatitis linked to GLP-1 agonists, and about, I think, 10 deaths in the context of that. Now, similar to the suicidal ideation, that did not bear itself out in evidence, but we do see general concerns for GLP-1 agonists and pancreatitis. So we do need to counsel people about extreme gastrointestinal pain if they take these medicines or they are prescribed in our setting, and they shouldn't be restarted if someone does have pancreatitis or they have a history of pancreatitis too. Drug interactions similar to metformin, they don't really have any, to be honest. You can get delayed gastric emptying, as I said, with the GLP-1 agonist, but you seem to build up tolerance to that. But if you had a drug within our therapeutic index, or where you were really concerned about getting optimal absorption, perhaps you would consider that in terms of your management strategies when it comes to using these. As I said, counselling on water intake is really important, and adequate diet, because you do see malnutrition with these meds, which we'll talk about on the next slide. Importantly, if because of some of the kind of homeostatic biological mechanisms for regulating blood glucose, if someone does not have diabetes or isn't on any blood glucose lowering medicines, you actually don't need to monitor. Again, similar to metformin, blood glucose, if you're prescribed these, it would just be if you were on something else. But again, you're going to be managed by diabetes in that case. So they can be prescribed safely in our setting. It seems as the 12% of you guys are doing, but they do have additional risk considerations. And aside from the RCT evidence not being there, this is an issue when we think about kind of blanket use of these medicines. So still have a favorable risk benefit profile in our cohort, but there are additional risk considerations we need to consider. As I said, malnutrition is something that's important too, because we're obviously not just made of adipose tissue or fat tissue, and muscle loss and bone loss is also really important for people who take GLP-1 agonists, which is where it's really important that compared to metformin, where you don't need to do this counseling, particularly, as I said, when it's used as that preventative or early intervention, with GLP-1 agonists, people should ideally be seeing diabetic colleagues so that they do get dietitian colleagues in the context of actually supporting people having high protein diets, having diets with enough fat, and also our colleagues in physical health too, with regards to exercise to maintain your muscle mass. So you can see in some studies, actually, the total weight loss that some people are losing with GLP-1 agonists, up to 40% of that was actually muscle and bone. So that's really, really important, and something that, again, we need to consider when we think about the appropriateness of their use in our setting. So to summarize, there isn't RCT evidence to support GLP-1 agonists as a preventative intervention. And because of that average 13.5% weight loss, if someone isn't in that cohort of people who are likely to gain a lot of weight with maybe olanzapine or clozapine, for example, or especially lower risk antipsychotics or ones in the medium risk profile, to induce a 13 or almost 14% baseline body weight will come with consequences for someone's physical health. So we do need to consider that even when we think about future preventative use. So really, these are going to be a treatment intervention, I believe. There are exceptions to that. As I said, if someone is living with an illness or a condition whereby there might be another indication for GLP-1s, like chronic obesity or type 2 diabetes, but again, they're probably managed by endocrinology or should be in that case. If they are prescribed clozapine, I do think there will be a role actually in the future as more evidence accumulates for these as preventative interventions, because people are likely to already have gained a large amount of weight by the time they get to clozapine. Most guidelines will say when you're using clozapine, obviously it's for treatment-resistant schizophrenia, and you will have tried high-risk medications already with regards to weight gain, particularly olanzapine. So it's likely that cohort of people already have a large amount of weight established that needs to be reversed, hence why you can make a different argument there. So we've put all of this, and this is the final reference, in a guideline that we made. So we, in Ireland, adapted Obesity Canada. They have an international guideline as well with regards to obesity management, and we made a chapter, or adapted their chapter, on the role of mental health in obesity management that gives recommendations for the use of both metformin and GLP-1 agonists. And importantly, it has this really useful table around dosing in all cases that might help people if they are using them in their setting or trying to increase support for their use. This might save you a lot of time because it looks at optimal dosing, deprescribing criteria, etc. And we tried to make it so that it would be a super useful resource for busy clinicians if they do want to use them and they can use them, actually how to optimally do so. So with that in mind, I'll stop talking. I have spoken for ages, so I'm sorry. It's a complex topic and it's difficult to get around everything, but I've put my email there if people do want to get in contact, or if we can help with sharing resources, more than happy to do that. Joe and I tend to hang around LinkedIn. Also, if you want to send messages, again, if we can help or answer specific questions to help get clinician buy-in, more than happy to do that. And obviously there's the chat as well here, if people are happy to stay on, or in the group chat too, in terms of our email list, more than happy to facilitate any questions as well. So hopefully everyone heard me okay, and I'll turn back on my camera and stop sharing my screen. Hopefully I haven't confused the life out of everyone.
Ita, thank you so much. I want to very quickly mention we are going to stay on. We appreciate we had a chat about this earlier in the week. We appreciate that we have covered a lot of material. So Ita and I are going to hang on for about 20 minutes, 30 minutes to be able to answer any questions. But we also know some of you have only got lunchtime. So if that's the case and you have to head off, we will continue recording this so you can access the questions and answers in the chat later. So if you have a question, put it in the chat. We'll come to the ones in the chat in turn. We won't respond to people with their hands up because we'll go through the chat in process. So if you've got a question, put it in the chat. What I want to say now is, come on, everyone, put your hands on, because if we were in a lecture hall, we'd be giving a massive round of applause. That was an awesome amount of material covered in a very, very short period of time. So thank you very much. We've got some floating hands there. So Ita, honestly, that was awesome. Gosh, there's like a whole module there of information from a whole term that you have like crammed into one thing. I can see you've got hands up, people with hands up, put your questions in the chat and remove your hands. So what I want to be able to say is, Lauren, can you please put a link in for the Gist Mail? So for those of you who are not part of the network, we can continue these conversations in the network via email discussion. So please join the network and then use that as a discussion board. Don't just wait for us to send you an information about the next seminar that's coming up. Ask questions, because this also helps us work out what are the topical areas, so we could then go and find the speakers to discuss that. The other thing that I think is very relevant to this one is in September, we are having a discussion. So it won't be a seminar series, it will be a discussion of trying to implement metformin within settings and the challenges and barriers that you are facing. And this is because I'm helping some people put together some QI projects for their particular settings, and they're facing some organizational challenges and barriers. If you want to join that, Lauren will also put the link in the chat so that you can sign up for that. Again, we will post all of this several times through the network as well. Ita, I hope you're kind of catching your breath, because you really did go into that at speed.
I know.
And we've had a few questions in the chat, so I don't know if you want us to just start reading through them and then we can have a look at approaching them. I think the best way to focus this, because of the number of questions, is to literally go down in turn, and then if we don't respond to someone, they can come back if they need more information. I think if we get people to come on, it's going to take too long for us to get through. And then the other thing I want Lauren to put in is our next seminar series is around physical activity in forensic settings, sorry. So you'd be interested in that if you want to learn how to improve your physical activity within a forensic setting. And we've got 2 on those, one in September and one in October. So should we start at the top with the questions and move forward? Is that how you want to do this?
Yeah, absolutely. I'm just trying to look at them. There's quite a lot.
Yeah, there's a lot. So I think, so like I said, we're going to be here for 20 to 30 minutes. Anything that we don't get to do, we can take over to the Gist Mail group to finish off. Okay, so it's about finding the first one, and yes, please use that group like Kath and Paul have, to be able to link and find other people within your trust, within your area, or across trust, to be able to help solve some difficult problems that you've got. So I think we're down to the first one, might be Jamie Jones.
Oh yes, okay.
More of a statement, I think.
Okay, which talks about obesogenic environments. I know. Yeah, I'm going to go to the first question, if that's okay.
Yeah, it's absolutely fine.
About topiramate, isn't that now contraindicated? Yes, it is contraindicated in females of childbearing age, but I've kept it there because that was in relation to the BAC guideline. They do reference it. Now that's from 2016, so obviously our evidence has changed. We don't use that as an intervention to manage antipsychotic-induced weight gain. Again, it's a studied intervention, so it's kept there. It's an option perhaps for some people, but it wouldn't be a standard option in anyone's case. No, so no, we don't use that. The next one I think is from Anthony. I'll just keep flying down through these, Joe, if that's okay.
Yeah, there's also one there asking if the BAC guidelines are going to be updated, and I think Ian Maidment may have some information on this. So Ian, if you know anything about that, can you just put the answer in the chat for me, if you're still here? I know you're planning to turn up, so I don't know if you're still here, but if you are, if you know anything about that, because I think you might, or I could be mistaken, in which case you can say, Joe, you don't know what you're talking about. All right,
yeah, because I don't know the answer to that one, but if anyone is involved in it and wants, if we can help work on it, that would be wonderful. If there was, just because obviously it's a guideline that's given prominence in our area. I'm just moving through the references. Link slide. Is there any advantage of tirzepatide over semaglutide or liraglutide? Probably, to be honest. In the general population, what you see is when they're compared to each other. So for people who don't know, tirzepatide compared to semaglutide or liraglutide, that works on one hormone. So the GLP-1 is essentially mimicking a gut hormone that we all have when we eat food. Our gastrointestinal cells release GLP-1, so we're just giving more of it essentially. So with tirzepatide or Mounjaro, which people will most commonly know, Zepbound, I think, in the US, essentially what that does is it has 2 gut hormones in it. So it looks at GLP-1 and GIP also. So you're kind of getting a more broader spectrum in terms of reducing appetite. When you look at comparative studies in the general population, you get about, so say that kind of 12-13% weight loss that you see in a year, you get about 20-21% average weight loss in reference to your baseline body weight with Mounjaro or the dual-acting medication. They haven't been studied at all in our cohort of patients, but it's very possible in the future that, again, in line with the GLP-1 agonists being used, that actually they will become much more popular from that side of things. So I hope that answers your question. Was there any mention of compounded effect of GLP-1 in patients who are on clozapine? This causes GI hypomotility. So in that particular study, they didn't find any increased rates of constipation. Now, it's only 31 people. That being said, and however, only half of them would have gotten clozapine. That being said, given how common it was, they didn't find, or how common, clozapine-induced constipation is, they didn't find any increased rate of constipation in that cohort of people. Or in that study. That being said, it would be something to monitor for in particular. We have lots of patients on GLP-1 agonists, many of whom are on clozapine. Actually, diarrhea is more of a problem, to be honest, with the GLP-1 agonists. And because we build up tolerance quite quickly to the delayed gastric emptying, it doesn't tend to actually present itself in clinical practice that much, but it is still something that I would keep an eye on. But it isn't a reason that I wouldn't use GLP-1 agonists in someone prescribed clozapine, for example. I hope that answers your question.
While you're scrolling down for the next question, Ita, I'm just going to get Lauren to put in the chat. We have one more poll, and these polls we are putting in because we have to give feedback back based on our funding for running these kind of events. So if you could just answer this, and all we're trying to do today is like get a word cloud again of what you've learned. And if you can do this while Ita's answering the questions, we can come to the word cloud at the end.
Is monitoring for amylase for pancreatitis needed? Great question. No, is the answer to that. We don't monitor for that. I'm not sure that actually it's quite good in terms of the research that it is quite sensitive to pick up people who are at higher risk of pancreatitis, and because the number needed to harm is so low in terms of it being 500. But no, it's not recommended as standard. Is there any recommendation for increased clozapine plasma monitoring? If started on GLP-1 agonist, or any evidence for standard reduction in dose? No. They don't have any pharmacokinetic interaction with clozapine, so no, there's no particular need to monitor or to change your standard monitoring that you would for clozapine assay levels that you're already doing. Georgina, what about use for under 18s? This keeps coming up, Joe. It's something we're going to have to do in terms of look at adolescent management of weight, because most of the trials for GLP-1 agonists have excluded adolescents, or they've only included adults where there is randomized controlled trials. There is lots of evidence for Metformin, so you can assume that you can use Metformin as a preventative or early intervention agent, as you would, or according to the guidance that we've given in this talk. But I think it's something that we're going to have to do a talk on in terms of CAMS and that particular.
Yeah, I think so. I mean, Ita, it might be worth this, because I've had a couple of conversations with the people up at CNCW, the giant super trust in the Northeast. I don't know if that's where Georgina's from, but there's a lot of interest up there in managing antipsychotic related weight gain. So it may be worth, the next time we have that conversation as part of the QI projects from Aston, is bringing you in, because they are coming at it from lots of different angles. Because obviously we've got the dietary and lifestyle advice, we've got the information, we've got parents and carers, we've got the obesogenic ward. There are lots of things that are going on there to try and disentangle. But I think a CAMS focused one would be good from different angles as well.
Yeah, I think so. Perhaps we can get a team of us on board, like to come do the pharmacological piece, and other people can look at it from other angles, because it is important. So we'll come back to that, Georgina. Thank you. Can I recommend the guideline development consider specific groups, especially people with a learning disability? You absolutely can. If there are 15 times more likely to be prescribed an antipsychotic, rates of obesity if treated with antipsychotics are 2 to 3 times higher. Early mortality, yes, absolutely. It's a really great suggestion. Maybe that's something as well, Joe, we need to document in terms of going down. But certainly if there is any, or if we're involved in any guideline development work in this area going forward, I'll make a note of that to look specifically at including that cohort of patients, because you're right.
Now, really I do know there is a set network for intellectual disabilities and SMI, I think that's what they did. So that might be worth us trying to find that out. Thomas O'Rourke, who's one of the academic psychiatric trainees doing a fellowship at Aston, introduced me to that network. So I'll try and see if we can find some information out, and we can share it via our network as well, because it could be that there's some information there that could potentially help answer those questions.
Okay. Yeah, I think I've seen that in the CMHP thread as well. Or McDonald might be involved in that one too. But yes, let's add that to the list of things that we need to look at, because that is really important, and I imagine a group that isn't considered adequately enough. So the point on decreased muscle mass malnutrition was interesting. How would GLP-1s have an effect on those with eating disorders, considering the risk of malnutrition? Gosh, that's a good question. I'm imagining wondering what context people with eating disorders will be started on the GLP-1, but at the same time, I'm thinking, or I'm going straight to anorexia there rather than binge eating disorders, for example, or not considering the broad context. I imagine there's quite a high risk there because you have additive factors, and really the purpose of that slide was to bring the risk of malnutrition into it, because it's something that we don't consider. We consider all weight loss or absolute weight loss beneficial when it's not. We know that our muscle is our powerhouse in many ways in terms of protecting our metabolic health. So it's certainly something that I would be really concerned about, and it's a very good point. I don't know, is the concern around malnutrition as great in binge eating disorders compared to people who are in lower body weight, but that could be my ignorance rather than anything else, because I'm not very experienced in eating disorders, to be honest. But if I've misunderstood or there's things you can add to what I've said, please do post it in the chat below. I would love to learn from that. Lauren has shared all the links, which is just super helpful. Thank you. Is there a time limit for duration of GLP-1 use in weight management? No, there is not. I know the NHS says something ridiculous, to be honest, around 2 years, but that again doesn't actually reflect our understanding of the pathophysiology of obesity or overweight more generally. People are born with a genetic profile that increases their likelihood of living with overweight or obesity. To treat them for 2 years or to offer treatment for 2 years and then take it away is equivalent to saying you have hypertension, I will treat for 2 years and then take it away. In our context, or with an antihypertensive and then take it away, in our context, for the duration that someone continues on antipsychotic treatment, they should stay on a GLP-1 agonist. There's no reason or rationale to say that if they stop the GLP-1, if they have lost a significant amount of weight, but they continue antipsychotic treatment, if it's reasonable that that's the primary cause of overweight or obesity, that they should stop it. Do you have weight management pathway that encompasses the guidelines? Weight management pathway, I suppose we have specific recommendations. I think I have probably put together a kind of algorithm based on that for our own local guidelines, and I can always share that in the GISC mail later. We've shared the GISC mail in the group, Joe, you said, haven't we?
Yes, so the links to join the GISC mail are in the group, so if anyone is not sure, you can join that link. If anyone's watching the recording and can't find the link, if they just actually, I think, put MHII GISC mail, JISCMAIL, it should come up in a Google search.
Okay. So I can add that in as well. Was going to ask, is there a guideline we can borrow to support? So that Metformin guideline that we made in 2021 is very inclusive in terms of recommendations. I just have a kind of a shorter pathway that is based on that. We've made those to be really useful to clinicians that you can actually just lift and implement, and they should be universally adaptable. So please do access that. And we made those with endocrinology as well, who it was kind of a merging of psychiatry and endocrinology, and that guideline at the end, the national one here. Those tables are essentially really tell you when to prescribe, like what are good kind of trigger criteria for I need to consider metformin or I need to consider a GLP-1, and deprescribing criteria as well. So both of those resources should be hopefully of help to you. But again, we might put them in the GISC mail afterwards as a summary of the links just for anyone that missed it. God, I'm moving down now again. Around clozapine, is the thought about NSDH at the point of prescribing? What about GI slowing and the risk of paralytic ileus and accumulation? Again, like general side effects with GLP-1 agonists, people just don't really tend to get constipated with them. It does tend to be diarrhea is the opposite in terms of water loss is the primary concern with them. Yes, it can happen and we would monitor for it, but on the basis of it doesn't happen that often, we can objectively monitor for it. People are likely to get more benefits from GLP-1s than risk. I wouldn't consider it as a major barrier. I know clozapine-induced constipation is really important that we monitor for that, and it can get dangerous quite quickly, but it's not something that I would see as a barrier to using GLP-1s. I would just keep my monitoring in place. And as I said, as that the delayed gastric emptying tends to reverse quite quickly, or it's not seen as part of the core mechanism responsible for appetite reduction, it isn't something that I would worry about excessively, to be honest with you. In our trust, we have a guideline. We have a 3 kilo weight threshold for intervention. Do you think it's better to change this given the limited effect of metformin? Yes, because 3 kilos to me, like it is the risk of adverse cardiometabolic outcomes, as I said, is related to the percentage, or the evidence is related to the percentage weight increase. So it's better to have a 5% weight increase, because 3 kilos in someone who's 50 kilos might not make that much of a difference, whereas 3 kilos in someone who's 100 kilos, that's a very different scenario. So it's more, it reflects better the pathophysiology of obesity and our general understanding of when we start to get negative adverse cardiometabolic effects once we actually have that percentage weight increase. So that would be better to do that. Are any other trusts getting weekly weights done? How are you managing this? I'm not going to answer that because unfortunately I don't know, but what I can say is that it is very, for something that is so easy to do and is an objective measurement, it's madness that, you know, it's not more easily done. There used to kind of be that thinking around, especially waist circumference, that it was intrusive, but actually we've done some qualitative research where we went and asked people about what their preferences were for weight gain guidelines in the area of antipsychotic-induced weight gain and weight management, and they don't mind being weighed. And either way, you can ask someone, do you have a preference to be weighed or not to be weighed? So to not do it, given the fact or the extent of overweight and obesity in our settings, is mad. We do weekly weights for 6 weeks, and then we move to every 3 months in people who are established on antipsychotics, but there are gaps as well. Oh, Ian is there now. He said about the BAP guidelines, there is no timetable yet. That might be something, Joe, we can maybe jump in on or speak to Ian about at another stage.
Yeah, I think so.
Which service is responsible for? That's a kind of local UK service, or UK based question. So I'm going to skip that in our setting, just to say we do prescribe them commonly outside of psychiatric settings. There is no requirement. Now the funding piece might be different, or influence your choice, obviously, but in terms, especially among our cohort of patients, in terms of safety, they can be prescribed in psychiatric settings safely once the knowledge is there around what you need to monitor for. But that was really the point we were trying to get across.
So
Chris,
I'm just going to jump in on that one, Ita, because this could potentially overlap with some of the discussion on metformin that we're going to have in September, because I think some of that will be around the responsibility, especially in the UK, of who is the responsible prescribing clinician for the adjuncts such as metformin and GLP-1s. Although the discussion is primarily around metformin, I think it might be interesting if you can join that, because I think the answers will be very similar, if not the same.
Okay. Yeah, fair. If we are going to come to the end of the questions, then if we're starting GLP-1s in any of our patients, are these lifelong? If there's an indication for them lifelong, either staying on antipsychotics, yes, is the case, to be honest. And this is very much now the understanding, again, in overweight and obesity management in the general population, that if there is an indication for a GLP-1 agonist, and usually these will be people who've lived with overweight and obesity their whole lives, that these medications should absolutely be continued as you would in the management of any other cardiometabolic syndrome. It's the exact same thing. So yes, they should be continued lifelong. If you're using them in the context of antipsychotic-induced weight gain, someone stops the antipsychotic, it makes sense to stop them unless there was another indication that it was being used for initially. But they should continue as long as antipsychotic treatment is continued. Kirsty, if we start them for patients, I'm assuming we mean GLP-1 agonists, with psychosis versus schizophrenia early on, can it prevent the multiplication of fat cells? My understanding is it doesn't reduce the number of fat cells, but they sit dormant empty. And that's why when stopped eating as we start, the weight goes back on. If we could stop or increase the number of fat cells early on due to reduced eating and weight gain, would this be better? Am I understanding the mechanism of action wrongly? I suppose they do that because they act centrally to decrease those appetite drivers, which are responsible for driving your appetite increase, particularly towards high energy, kind of high carbohydrate foods. I am not aware of anything on the dormant empty piece that you said. I suppose when you're saying about stopping the fat cell accumulation, that's really where the benefit of that early metformin use is, and then GLP-1 agonists to reverse accumulation of or to reduce the already occurred accumulation of fat cells. But that is not my understanding of how that works. But again, if I'm missing something, please do let me know or put it in the chat below. I'm always happy to be corrected. People are having kind of conversations with each other, so I think I haven't missed any of those.
I don't think there's too many more questions.
I think that might be it. People are probably tired and hungry themselves at this stage.
Yeah, I think everything else has been, I think it's like lots of, interest. So there's definitely something here I think that we need to talk about in relation to CAMS, Ita, even if we end up having a discussion similar to the metformin one in coming months, which you may or may not be able to attend. But it might help start to get the ball rolling and work out what the particular areas of focus need to be, which then can help us identify the appropriate experts as well. So yeah, I think that might be, I think it's a very, this whole area is very much under researched. And then when you add in the specifics of the population within the population, such as intellectual disabilities and then CAMS, then the area, just the lack of research just gets bigger. Well, the gap gets bigger. But thank you so much to everyone. I can hang on for another 4 or 5 minutes.
Yeah, wait.
2025 is pretty full. So we've got Dr. Toby Keel in September, who's going to be talking about how you can do physical activity and what is required within forensic settings. In October, we've got Mike Holt from over in the Northwest, who'll be talking about park runs in forensic settings. Then in November, we've got Professor Carolyn Chu Graham and Dr. David Shires, who are going to be talking about physical health management of SMI within primary care. And then in December, we've got this new hotly awaited report from the Royal College of Psychiatrists around managing physical health in SMI. I can't remember the exact name of the report. I think I have been given it, but I can't remember it. But that'll be December's, and we will post updates with the times and the dates as we go. The time will always be lunchtime. Will always be 12 to 1. But obviously the dates, and we will vary the days, because some people can't make, a Wednesday or a Thursday. So we will try and vary the days, and they'll be very led by the individual clinician as well, the individual clinician / researcher, whoever's doing the talk. But if anyone has any ideas about things they would like us to focus on, or has any questions, just use the GIST mail. That's probably the easiest way to make us alert to it, and then we can all chip in. We've had some interested people approach us about 2026, so hopefully we'll have an exciting lineup. I think we could have one a week with the interest in this area. We just don't have the time.
I know, and it's hard, isn't it? Because you want to, when I'm making these slides, it's the pressure to fill in as much as you can, but as well, while people have the time to attend, because obviously that's hard, but it's complex. There's a reason why we keep getting the interest in it, to try and figure it out, and we're learning as we go as well, to a certain extent, which is difficult. But I just hope that today was informative rather than overwhelming.
Today was amazing. And obviously there's the recording. So if people felt the information was coming at them at quite a fast pace, the recording will be up on YouTube. If you subscribe to the YouTube channel, you'll get a notification as soon as it's live, and you can watch it as slowly as you like, because you can just pause it, look at the actual research papers and we'll put all of the references will go in a comment underneath the actual recording, so that people can easily access all of the individual references that we've got as well.
Yeah, you're right. Well, listen, maybe Joe, you and I'll hang on, but we'll let everyone else go.
That's okay. So thank you so much, everybody. It's nice to see all these little circles. Thanks, Kirsty, for turning on your camera.